currently we are using artificial intelligence and augmented reality. We are using currently in our setup. Assalamu alaikum. Should we start? Today's program is an awareness program for knee health and orthopedic related knee programs. Myself, Dr. Shekh M Khan, Associate Consultant, Orthopedic and Joint Replacement Surgery, Fortis Hospital, Jaipur. As in our medical fraternity, there is a trend of introduction. Myself, I have done my MBBS from SMS Medical College from 2010 to 2015. Then I have done my MS Orthopedics from Sports Medicine from CK Villa Hospital, Gurgaon, under able leadership of Dr. Manu Bora. Then I completed my fellowship in arthroplasty joint replacement in Fortis Hospital, Jaipur, under the able leadership of Dr. Bhattansari. First of all, we will start from complex trauma around knee joint. In case of a periarticular fracture, perfect bone reduction is of paramount importance. If not reduced anatomically, then it may lead to arthritis in future. In a periarticular fracture, if not reduced anatomically, it may lead to an uneven articular surface, which is a cause of friction at articular surface, and this uneven surface lead to cartilage damage with every movement of the knee joint that lead to knee arthritis. And in severe grade knee arthritis, the only treatment is total knee replacement. It is an example of a complex periarticular fracture, proximal tibial condylar fracture, both condyle involved. It was well reviewed and articular surface is well mentioned. Importance of soft tissue management in complex periarticular trauma. In case of a trauma like capsule, tendon, ligament injuries are ignored. If soft tissue management is ignored, it will lead to a bony union or a reduced joint, but a functionally less, not a properly functional joint. Here is an example of a young boy with knee dislocation. It is a photo of that particular knee. He developed blisters over time. On further evaluation, there was medial joint capsule, deep MCL, superficial MCL, and all medial hamstring tendons were torn, so repaired anatomically. All the ligaments, all the soft tissue structures were first taken properly. All the structures repaired in anatomical conditions. After 4 months, patient is running comfortably. Even there are no ACL PCL repaired in his knee. Without ACL PCL, there is so much stability that he is running comfortably. Multi-ligament injuries of knee. In case of joint dislocation, in most common cases, there are multi-ligament injuries. Initially, multi-ligament injuries should be managed conservatively to get full range of motion before we jump into surgery and ligament reconstruction. In most of the cases, MCL, medial collateral ligament heals by conservative management without any surgery. Then we can proceed with stage or single stage intra-articular ligament surgeries. Even if conservative management fails, then we can proceed to stage or single stage surgery with proper pre-op planning. Pre-op planning in this kind of surgery, this kind of cases is paramount importance.
This is a case of ligament injury. Patient is having ACL ligament. There is a positive USF test. Patient is having positive USF test, and there is a left one completely less, and positive side test is also present. As we can see, this positive side test is also present.
broad neck, so chin is completely less, and as you can see, ankle is less, and 0 degree, and at 30 degree. Ankle is completely. After completion of process, we have taken 70 graph to the other side, 10 graph to the other side, and 1 pedal graph to the same side. After completion, we can see this is fairly stable, and initial opening is gone. It is fairly stable. This was a case of multi-ligament injury. Patient was having ACL injury, PCL torn, MCL torn, and middle meniscus injury. It was managed in a single stage. Patient is having complete range of motion and comfortable walk after 3 months of the surgery. आप अभी चल पा रहे हैं आराम से? Regional AC ligament surgery in national cases, anatomy is slightly distorted. So a 30-year-old national athlete got his ACL surgery done somewhere else few years back, but unfortunately his reconstructed ACL got torn again. Now what? Latest technique of ACL reconstruction, that is all inside ACL reconstruction with fiber tape internal legs. After the surgery, national level gold medal after the surgery. After, he underwent 90 degree. Disease and his infection, he was not able to do his day-to-day activities. As we see in arthroscopy, we see hand-in-hand knee pain. Various conditions which can be cause of misdiagnosis, especially in adults more than 50 years of age, because sometimes we think tubular vision, we have single vision of osteoarthritis. We have encountered various cases where patients were advised total replacement even in grade 1 or grade 2 arthritis because of misdiagnosis. Here is an example of 64-year-old female having knee joint pain and unable to do her day-to-day activity. Because of that, she came to us for total replacement as she was advised earlier at her local level. On X-ray, she was having only grade 2 osteoarthritis. On clinical examination, she was having medial joint hand tenderness, applet test positive, McMurray positive. She was diagnosed with, on final diagnosis, she was diagnosed with medial meniscus root tear. We repaired it arthroscopically. After surgery, she was having complete range of motion. Only problem. Complete range of motion. 53-year-old male having knee joint pain and unable to do his day-to-day activity because of that. Same story, he came to us for total replacement as he was convened for his total replacement surgery. On X-ray, he was having nearly grade 2 osteoarthritis. On clinical examination, same, he was having medial joint tenderness and swelling around the medial joint pain. We advised MRI. On MRI, para-meniscal cyst of medial meniscus was there. He was operated arthroscopically. Again, keyhole surgery, minor surgery. On day 2, patient can do everything. It's a daycare surgery. There are few more conditions which can be treated conservatively or with minor surgical procedures like arthroscopy or even physiotherapy. Example, ACL mucoid degeneration many times. This diagnosis is osteoarthritis, reactive arthritis, chondromalacia patelli is a common cause of anterior knee pains, and various other complex meniscus tears. They can also be managed conservatively, physiotherapy or minor arthroscopic surgical procedure, keyhole surgery. So, total knee replacement should never be done, or when we should consider total knee replacement as treatment of choice. TKR, when to do. Pain persists or recurs over time. Pain worsens after bedbearing activities, prevents you from sleeping, decrease in knee range of motion. Stiff or swollen knees, difficulty in walking or climbing stairs, difficulty in getting in or out of the chair, morning stiffness, analgesic requirement more than twice a week, and most importantly, after removing all other possible differential diagnosis, because this is one of the major surgery for the knee. So we should consider it in the end after removing all the differential diagnosis, after excluding all those. Nowadays, also in total knee replacement surgery, concepts are being changed all the time as new implants and new techniques are emerging. Concept change number one: second posture day, we can now make patient walk. Important requirement: perfect balancing of extension and flexion gaps. Can even mobilize without assistance. Patient is walking on date of the surgery. Even walking is possible without brace, without walker. But she was done MCL pie testing we have done in this patient, so we gave him braces. Concept channel 2, second part of week, we can now make patient resume his usual activities. Important requirement, again perfect balancing and good physio and digestion of quad power. Can even go upstairs without assistance. This patient was mother of my junior, Dr. Rohit Jagar, who is the physician. Concept 3, TKR can now be done in obese and high BMI patients. Important requirement, availability of new implants like neoprene coated implant, third generation polyethylene. Can last longer than normal implants. She was my auntie and she was very obese before the surgery. At 3 months, she went for Hajj, mashallah, and she is also an obese patient. Consulting 4, patient can now sit cross-legged even after total knee replacement. Important requirement, again perfect balancing of flexion gap, extension gap, ML, AP gap, good physio and high flexion implants. 50% of patients can even sit cross-legged as early as day 2. Even before stitch removal, patient is sitting comfortably cross-legged. Concept change 5, can sit as low as 1 feet above ground. Important requirement, perfect balancing, good physio, high flexion implants, sitting comfortably on 1 foot height and cross leg. Concept change 6, second posture we can now make patient climb stairs without support and walk with a normal gait and good walking speed. Important requirement, again perfect balancing, good physio, resumption of quad power, can even go upstairs without assistance. Dr. Farooq Khan, PMO, Makarana Government Hospital. आपको कितने साल तक देखी है अभी फारूक को मैंने जो अपने पीएमओ इंचार्ज अपना गवर्नमेंट में चलता थे ऑपरेशन पहले कितना चलता था तो अभी कितना चल रहे हो हाँ लगभग 1 मिनट चलते हो ऑपरेशन कितना टाइम हुआ है आपको कैसा फील हो रहा है we expect 1 kilometer walk after 1 month of the surgery, 2 kilometer walk after 2 months, 3 kilometer at 3 months, and 4 kilometer at 4 months of the post-operative period. Concept change 7, even severe deformities can be corrected. Again, in fact, important requirement is perfect pre planning, because in deformed knees we have to plan accordingly. We have to manage all kind of implants which may be required. Availability of stents and wedges.
60-year-old female, advanced by 2 months. 20-30 degree system. 60-year-old female, both the replacement operations से 2 हफ्ते पे आ जाओ मैडम, चलो चलो आराम.
Visible difference.
ऑपरेशन से 2 हफ्ते पे बिना सफाई बिना स्टे बिना होगा आराम से चलते हुए. सीढ़ी चढ़ते चलते हुए दोनों पैर से वापस आ जाओ माता जी.
Concept change. Minimal port of pain in physio and walking, important requirement, good surgical technique, and good coverage of perioperative analgesia. Can even walk males and just 12 hours after surgery without any pain. Patient is asking कैसा लग रहा है आपको? Few interesting cases which are not normally encountered in day-to-day practice, whereas with uncontained defect, 60-year male person presented with pain, difficult in walking for last 1.5 years, or in 30 degree of balance, which are not correctable, effective 15 degree range of motion between 28 degree practice patient, painful range of motion, preoperative planning, pipeline, radiology was done, which show 30 degree balance, uncontained MPC defect, and severe osteoporotic angle neck difference. This was the X-ray, very bad X-ray. This was the intraoperative defect in the knee. It was measured. Tibia cut at 11 mm from LTC, 3 degree posterior slope, MTC. These are the planning which we carried out during the surgery. MTC had 1.5 to 3 to 5 cm content bone defect. Tibial base plate measured and tibia trial with 5 mm into 3 wedges on MTC was taken. Medial lateral gap balancing was done by MCL by testing reduction of osteotomy. After tibial reduction of osteotomy, central tibial fracture shifted towards lateral, so finding central canal tibia pushing. Well prepared jigs. This was the port of X-ray, perfectly aligned and normal alignment. 5 mm to 3 metal wedges used to manage MTC and content defect. This side we used 3 metal wedges to cover the defect. Final concussion implant 3 to 5 mm wedges used with central tube stem. Complete correction of pipeline deformity was ensured intraoperatively. Pipeline radiograph showed well-placed implant with correct limb alignment. 30 months follow-up radiograph showed no evidence of losing of prosthesis. Patient have range, complete range 0 to 135 degree. Again, in interesting case, whereas content defect with a bone tumor, there was a bone tumor in tibia. 54-year male, again same presentation, but pain was out of proportion to the deformity and increasing rapidly. Examination, 10 degree various deformity was slowly progressive and passively non-correctable. Painful range of motion, no effective hyperextension. Preoperative planning, pipeline radiographs, similar planning. MRI was done, which suggested bone tumor with size of 3 into 3 into 5 cm, with no neurovascular involvement, possibly benign tumor. Intraoperative biopsy was taken and sent. Report showed chondromyxoid fibroma. TKR plant with selected PS non-constant design. There was osteoarthritis with bone tumor, which was a challenge. Again, standard medial approach used femur prepared 8 mm tibia was taken with 3 degree posterior slope, soft tissue balancing, reduction of osteoporotic varus. As we can see, there is a big bone defect because of removal of tumor. MTC medial tibial condyle bone tumor was exposed. Bone tumor was excised en masse. Pretense of extremities was done. K was taken not to convert a content defect into a content defect. Margins of defect was chemically coated phenol so that future recurrence of tumor can be avoided. Bed was prepared so that bleeding bone can be achieved, so that bone graft infection and union can be achieved. Bone cement should not go in between the bone graft and hot bone. It created a content defect on medial tibial condyle 3 into 3 into 5 cm. This bone defect, because of bone tumor, was filled with bone graft. Well-aligned, normal, anatomical condition post-operatively. Post-operative showed well-placed implant with correct alignment, bone graft well fit in place. 18 months follow-up radiograph showed union of bone graft with no evidence of loosening of processes. Patient had range of motion due to uncertified degree. Again, interesting case. Post total knee replacement, patient fall and fracture of medial tibial condyle happened. Uncontent defect. 69-year female. Operative case, totally replacement, 7 months death. On examination, pre-operative planning, bilateral knee radiographs showed post-TCAR peri-prosthetic fracture of the medial tibial condyle. Tibial base plate loosened, whereas 30-20 degree TCAR was planned, cemented, PS semi-custom design. Standard medial vascular approach, femoral implant prepared, tibial base plate was removed in cement. Development done. Five mm into 3 wedges used to manage the anti-sand content defect. There is extra 5 mm wedges placed to cover the bone defect was created because of fracture of the medial tibial condyle. Valgus knee with content defect, 46-year female. Pain and difficulty, similar presentation on examination, passively partial fracture, completely valgus, not 50, range of 1 to 1 times, characters present. Pre-operative planning, bilateral radiography show 30 degree valgus with content defect over lateral tibial condyle. This big defect. Intraoperatively, bone defect was covered by bone graft with just fixed with a screw. Post-operatively, semi-constant implant was used as medial lateral stability was of paramount importance. Centered medial lateral approach. Tumor prepared. 8 mm cut 3 degree standard. Content bone effect of 5 into 3 into 3 cm over lateral tibial condyle. Gradual valgus correction done by lateral capsule lesion, IP release. Care was taken out to convert a content defect to uncontent defect. Bed was prepared to get bleeding bone so that bone graft infection can be achieved. Bone graft plate and filled with screws. Screw was compression into bone. 2 years follow-up of radiograph showed union of bone graft with no evidence of losing of oxygen. Patient walking, doing all his daily activities comfortably. Again, a valgus knee with content defect. This was a content defect, valgus knee. 56-year female. Similar presentation for past 5 years on examination, winds of deformity, right knee, valgus 40 degree. Passively partially correctable. Range of motion, painful 10 degree hypertension. Pre-op planning, similarly bilateral axis and all. TCAR planning, cemented PS, semi-custom design, standard medial. And still found to be late and lateral suture tight, gradual valgus correction done by releasing lateral capsule. Iliotibial band release and popliteal spike casting. Bone graft with screw was planned. Bed was prepared and taking care not to convert a content defect or content defect. Bone graft taken from femoral cut was prepared and placed with this present with screw that was compression. This was the defect, very big defect. Again the defect was covered by bone graft and which was fixed with a screw. Semi-constant implant used after ensuring well fixing of graft. Trial was taken which was stable with no movement. Semi-constant implant. Bone cement perforation between bone graft and whole bone was prevented. Complete correction of bilateral deformity was ensured intraoperatively, post-operative complications. There was one partial creation in margin necrosis occurred due to poor subcutaneous tissue, which recovered in 2 months. Common peroneal neoplasia due to acute valgus correction recovered in next 4 months. There was 2 complications in this surgery post-operatively. One is partial dehiscence because there was very less sufficient tissue which was recovered in 2 months, and due to acute valgus correction, CPM nerve gets straight and which was recovered in next 4 months. 6 months follow-up radiogram showed union of bone graft, no evidence of union processes. What we are planning for future, there is artificial intelligence and augmented reality which helps in better cuts, better alignment for knee replacement, which we are using artificial intelligence and augmented reality we are using currently in our setup. And in coming future, we are planning to have a robot in our setup for total knee replacement and total hip replacements. These are few achievements. My important achievements. Back in 2006, I got ranking merit. In 2010 board examination RBSE, I managed to get a rank in merit list in 2008, and I got award from Vasudha India at the time CM. Multiple interviews in various newspapers at that time back in 2008. Former Governor Pandit Naval Sharma and former BJP State President Ashok Bannerjee back in 2008. Council of Scientific and Industrial Research Program 2008. Appreciation letter from Yunus Khan at the time Minister in the Assam government. Tariq Anwar, blog by Tariq Anwar. Appreciation letter from Raj Kumar, President of the Assam Board. Gold medal award received from RBC Chairman Betty Donate. I appeared in 12 board in 2010 and I secured 28 in RPM 360. Develop a passion for learning. If you do, you will never cease to grow. Robert Dabrad, MD, complex knee sports medicine specialist from USA. He is considered as one of the best sports knee surgeons all over the world. Dr. Gilbert Moitze, MD, PhD, Oslo Sports Trauma Research Center, Norway. Dr. Rajiv Raman from Kolkata. Dr. Gurwa Reddy, Section of Hyderabad. He is considered as pioneer of orthoplasty in India. Our work and efforts are acknowledged by print media. Back in 2021, I was working in Jalore district, and first total replacement of Jalore district was done by me. First total hip replacement in Chiranjeevi scheme. The patient was driver of Minister Sukhramji Bishnoi, and this was the first total hip replacement done in CSBI scheme. First arthroscopy surgery in Jalore district was done by me. Due to our continuous team efforts and dedication for patient care, we have been appreciated by our patients and public representatives as well. Total hip replacement patient from UK, leg bone fracture patient from France, ACL patient from Iraq, wrist fracture patient from Italy. Fatehpur MLA Janab Hakamuddin Khan Sahab, I have done his son's surgery when I was in SMS in July 2023 for leg bone fracture, and he came to my OPD for consultation of his wife for knee arthritis. Adarsh Nagar MLA Rafiq Khan Sahab. We have done multiple surgeries for Yunus Khan's sister in February. last but not least, my guide, my mentor, Dr. M Khan sir, who is always standing beside me, whether it is personal or professional. Thank you so much.